Let's get right into it. Welcome to this explainer where we're going to completely master two of the most famous signs in neurology. Our focus today? Total comprehensive mastery. We're breaking down the physiology, the anatomy, the clinical variations, literally leaving no stone unturned, so you absolutely will not need to open a textbook after this. Whether you're prepping for rounds or you're just fascinated by the complex wiring of the human nervous system, you are exactly where you need to be. All right, let's run through our agenda for today. We're going to hit the plantar reflex basics, trace the exact neuroanatomy, look at etiologies and differential diagnoses, explore variations in eliciting responses, and finally unpack the Hoffman sign.
Kicking things off with Section 1, the plantar reflex basics.
So, named after Joseph-François Félix Babinski, a brilliant French neurologist from the late 19th century, this primitive reflex is totally normal in infants. You drag a noxious stimulus up the foot and the great toe extends. Now, here's a super important caveat. You've probably heard people talk about the small toes fanning out, right? Well, actually, scratch that. While the small toes might fan out, that fanning is not consistent, and honestly, it's not clinically important. The real diagnostic magic, it's all about the extension of that great toe.
Now, in healthy development, this reflex usually vanishes around 10 months of age, though, to be fair, the normal range is massive, anywhere from 6 months all the way up to 12 years. So why does it disappear? It's basically all about central nervous system myelination. As your CNS matures and adds that myelin insulation, it creates a powerful inhibitory control over this primitive circuit. Once that's locked in, the response flips from extension to your normal adult plantar flexion.
Which brings us to the absolutely crucial concept of unmasking. If you get an upper motor neuron or UMN lesion anywhere along the pyramidal tract, from the motor strip all the way down to about L4, you lose that hard-earned inhibitory control. The primitive reflex is unmasked. Boom, the great toe extends again. And in really severe UMN lesions, you might even trigger what's called a triple flexor response. That's ankle dorsiflexion, knee flexion, and hip flexion, all firing off at the exact same time as the toe extension. It's pretty wild.
Moving on to Section 2, the specific neuroanatomy of the reflex.
Okay, this is the exact loop you need to commit to memory. It's a 3-step journey. First, the afferent limb starts with cutaneous receptors strictly in the S1 dermatome, traveling up the leg via the tibial nerve. Second, it hits the spinal cord, processing within segments L4 through L2. And finally, the efferent limb shoots the motor signal back to the toe extensors via the peroneal nerve. So, S1 via tibial, synapse at L4 to L2, return via peroneal. That is your complete circuit.
Let's jump into Section 3, etiologies and differential diagnosis.
Now, lesions that produce a Babinski sign don't always have to be structural or permanent. They can totally be functional and completely reversible. Look at the structural side. You've got spinal cord injuries, cervical myelopathy, hematomas, or internal capsule lesions from strokes or tumors. But check out that other column. You've got reversible causes like toxic metabolic comas, the post-ictal state right after a seizure, TIAs, and even hemiplegic migraines. And yeah, progressive motor neuron diseases like ALS are major culprits here too.
But before we move on, I have to point out a massive clinical pearl. In acute spinal cord injuries, you'd probably expect an immediate Babinski sign because of the huge UMN damage, right? Well, actually, the plantar reflex might be completely absent at first. This is due to spinal shock, a temporary phase where literally all reflexes below the level of injury just shut down. It's only after that spinal shock wears off that the classic Babinski sign is finally unmasked.
All right, Section 4. Variations in eliciting responses. The absolute gold standard technique here requires the perfect noxious stimulus. You stimulate the lateral plantar surface and the transverse arch of the foot. But here is the secret sauce. It has to be a single, smooth movement lasting exactly 5 to 6 seconds. If you go too fast or press too lightly, you just aren't giving the system the input it needs to accurately trigger the arc.
Now, you can actually elicit this exact same reflex outside the S1 dermatome using a bunch of different eponymous heavy maneuvers. For instance, the Chaddock maneuver, scratching the lateral foot. Believe it or not, this catches about 3% of positive cases that the standard plantar swipe actually misses. Then you've got Schaffer, where you aggressively pinch the Achilles tendon. Oppenheim is sliding your knuckles hard down the shin. Gordon is a quick squeeze of the lower gastrocnemius. Bing uses light pinpricks, and Gonda, or Stronsky, is where you pull the 4th or 5th toe down and out, letting it snap back. All these wild maneuvers, They're all testing the exact same upper motor neuron integrity.
Finally, Section 5, the Hoffman sign explained.
Shifting to the upper extremities, we have the Hoffman sign, named after Johann Hoffman. This basically tests for a similar UMN interruption, but in the arms. To do it, you flick downward briskly on the nail of the patient's middle or ring finger. A positive response is this involuntary, twitchy flexion of the adjacent fingers or the thumb. But here's the catch, and it's a big one. A weak version of this flexion can actually be present in perfectly normal people. It is definitely not as black and white as an adult Babinski.
And that brings us to the core physiological difference between the two. While they both flag UMN issues, their wiring is totally different. The Babinski is a lower extremity multisynaptic pathway. Hoffman's, on the other hand, is an upper extremity reflex that uses a super-fast monosynaptic pathway. That single synapse, it happens right in rexid lamina IX of the spinal cord.
So how do we actually interpret this sign correctly in clinic? Like I said, it could be normal, especially in younger folks who just happen to have naturally brisk reflexes everywhere, maybe even a positive jaw jerk. But when it is truly pathologic, it points to a disinhibition of a C8 reflex. This means your lesion is sitting somewhere above C8. To put that in perspective, this sign shows up in about 68% of patients who end up needing surgery for cervical spondylotic myelopathy.
But check out this statistic. It absolutely blew my mind. Researchers looked at patients who came in strictly complaining of lower back, lumbar symptoms, zero obvious signs of neck or cervical issues. In that specific group, if they had a bilateral Hoffman sign, it revealed hidden, occult cervical spinal cord compression an unbelievable 91% of the time. It perfectly shows how flicking a finger can uncover a silent time bomb higher up the spinal column.
But let's keep it real and look at the hard diagnostic stats. When we grade the Hoffman test strictly on its numbers, it's honestly a bit all over the place. Sensitivity is sitting between 33% and 68%, so it's missing a lot of disease. Specificity is 59% to 78%. And the positive predictive value, meaning if the test is positive, do they actually have the disease, is super low, ranging from just 26% up to 62%. Negative predictive value is only slightly better at 67% to 75%.
Which brings us right to the ultimate conclusion of our source material. Despite its legendary fame, the Hoffman sign simply has too low a predictive value to be relied on by itself as a standalone screening tool. It's a clue, sure, but it has to be just one piece of a much larger clinical puzzle. So, I'll leave you with this. Knowing what we now know about the unmasking of these ancient, primitive pathways, how much weight will you really place on a simple toe extension or a finger flick the next time you're assessing a nervous system? Keep digging, keep questioning, and I'll see you in the next explainer.